at the ages between 35 and 45, and 90% individuals who are diagnosed with the cervical precancerous cancers receive the treatment. Australia is on the track to become the first country to eliminate cervical cancer by 2030. Our government is also launching the vaccination program for 14-year-olds. So, persistence and the hard work of our seniors and people passionate about cancer elimination are there who are doing everything. There are cancer deaths in India after 2016. So the government suggested that VIA-based screening alone is insufficient. Keeping all this in mind, we are here for today's webinar with the stalwarts here. Dr. Sharda Jain Madam, Dr. Veena Acharya Ma'am, Dr. Reena Srivastav, Dr. Shyam Pyari Madam, Dr. Sarveshwari, Dr. Mala, Dr. Vandana Verma, Dr. Sadhana Gupta, and our chief guest, Padma Shri, Dr. Neeja Bhatla Ma'am. My respects to all the guests, all the teachers and mentors who are here, and your insights will enlighten us, enlighten our minds, and they will be beneficial for our patients and all the attendees of this webinar. Without any further ado, I would request Mr. Roshan to start the Ganesh Vandana so that we can begin our welcome and academic sessions.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि.
Invoking Lord Ganesha and seeking his blessings. Now I invite the NIGF UP chapter president, Dr. Hema Shobne, to give her welcome address. Dr. Hema Shobne is head of the department, Maharani Lakshmibai Medical College, Jhansi, a very dedicated, simple and brilliant teacher, a great administrator, and also a wonderful organizer. She organized the 3rd annual conference of NIGF at Jhansi. She is achiever of many awards and has many publications to her credit. Over to you, Shobna ma'am.
Okay. Thank you, Dr. Amrita. Very good evening, you all. It is both an honor and privilege to welcome you all on this wonderful webinar on behalf of UP chapter NIGF to make success of today's webinar on 90-70-90 cervical cancer that is preventable and curable if detected early and treated at the right time. We are delighted to offer the most hospitable welcome we can. It is my pleasure to extend a hearty, cheerful welcome to our respected Chief Patron, Dr. Sharda Jain Madam, Honorable President, Dr. Ragini Agarwal Madam, Secretary General Dr. Sudha Sharma, and past NIGF President, Chief Advisor of UP Chapter NIGF, Dr. Sadhana Gupta Madam. All of you are very unique with distinct vision, fountainhead of illuminating ideas and idol of knowledge, experience and inspiration to all of us. We are deeply honored to welcome you all as esteemed dignitaries and honored members, all office bearers, mentors, teachers. On behalf of NIGF, I would like to express our warm welcome and heartfelt greetings to our respected chief guest, Professor Dr. Neeja Bhatla Madam, HOD AIMS Delhi, for being here and her wholehearted support for being a pillar of strength and source of inspiration. I extend my sincere gratitude to our distinguished chairpersons, Dr. Veena Acharya, ex-professor and HOD SMS, Medical College Jaipur, Dr. Mala Srivastav, senior consultant and robotic surgeon, Sir Gangaram Hospital, Delhi, Dr. Reena Srivastav Madam, ex-HOD BRD Medical College Gorakhpur, Dr. Sarveshwari Nautiyal, retired Director, Medical and Health Services UP. Your gracious presence and you are doing extraordinary work in NIGF beyond expectation, serving with distinction and leading with impact is inspirational to all of us. We extend our heartfelt welcome to today's esteemed speakers, Dr. Vandana Verma, Professor and HOD, AIMS Library, Dr. S.P. Jaiswal, Madam, ex-HOD, OBG, KGMU Lucknow. It is a great opportunity to all of us to hear you both on this important topic on cervical cancer prevention. Most of these deaths are occur in low and middle income countries due to limited access to screening, vaccination and treatment services. Death from cervical cancer is nearly 100% preventable if the precancerous lesions is detected early and treated at the right time. Your visionary talk, knowledge and inputs, definitely it will instrumental in our day-to-day practice. I would like to take a moment to express a heartfelt welcome to our organizing team behind this webinar, Dr. Amrita Jaipuria. She is a main leader of this show, and Dr. Apala Priyadarshini, treasurer, for your tireless efforts and unwavering dedication support to UP chapter NIGF. My special welcome to all respected teachers, dear members, colleagues, residents for your presence, your participation, and your support to this organization. Teamwork makes the dream work, and all of you are true example of it. Coming together is a beginning, keeping together is progress, and working together is success. I am honored to get this wonderful opportunity to work alongside each of you with utmost sincerity and transparency. With this, long live NIGF, and I would like to hand over mic to Dr. Bharti Maheshwari Madam for further proceeding. Thank you.
Now I invite Dr. Bharti Maheshwari, who is the head of the department OBGYN at Muzaffarnagar Medical College. She is also heading the IVF unit there. She has held many positions locally at Meerut and at Muzaffarnagar. She has also been the chairperson of MTP committee Foxy, and she's a hardcore teacher, a great Foxian, and she has worked very hard for whatever job she has been assigned. So over to you, Dr. Bharti, to welcome and invite Dr. Sharda Jain Madam and Dr. Ragini Ma'am for their words of wisdom. Over to you.
Am I audible, Dr. Amrita?
Yes,
I'm
Dr.
not
Bharti.
able to hear anything.
Dr. Bharti, we can hear you. We can't see you, but we can hear you. रोशन जी आप चेक करेंगे क्या?
She says that she is not able to hear anybody. So how to communicate?
Am I audible?
Yes, ma'am.
Yes, ma'am.
Hello.
फोन करके बता दो.
Yes, you are audible, Dr. Bharti. एक सेकंड बता रहे हैं.
Am I audible?
Yes.
Yes, Bharti. Should we continue, ma'am? There's something. रोहन जी, रोशन जी, आप बात कर लिए?
मैम बात कर रहे हैं एक सेकंड.
Amrita, till then you can invite your people.
मैम से कनेक्ट नहीं हो पा रहा है अभी.
अच्छा कोई बात नहीं. So I have the privilege of inviting Sharda Jain Madam, introducing her. She's a very prominent figure, very eminent personality, director of Life Care Center and Life Care IVF. She has led the Delhi Gynaecology Forum and NIGF as a patron. She is the ethical committee member of NMC. She is an expert in DMC, the Delhi Municipal Corporation, since 2009. She is a medical activist, be it for the female child, or for the cancer elimination or anemia elimination. Or now she is very passionate about PPH elimination, death because of PPH. She wants to eliminate it by 2030. She's a living legend. And over to you, Sharda ma'am. We are proud to have you on this platform because you brought us the concepts of Janani Suraksha Yojana and Asha workers. So it's great for us. Over to you, Sharda ma'am.
मैम नहीं
ज्वाइन किया
नहीं ज्वाइन
Okay.
Now I think, am I audible? Now I can hear you, Dr. Amrita.
Okay, Dr.
Yeah.
Bharti,
Yeah.
you can invite Dr. Ragini.
Yeah. So, first of all, welcome all of you in this very informative NIGF webinar, and congratulations to Dr. Amrita Sarkari, Madam, and her team. And as you all know that Dr. Amrita already told about Dr. Sharda then Madam. She is the inspiration and motivate all of us to do good work. And on the same platform, Dr. Ragini Agarwal, she is the president of NIGF, and we all know that she is what I must say that really a root level worker, I think, and she motivate all of us to work from the ground levels for all women health programs. And what I know her, she is currently the director at the Dr. Ragini Clinic and Women Health Center, as well as she is very well known aesthetic clinic, as well as known in the all high risk pregnancy, adolescent health care. She has nowadays the secretary IMS also, and she was the former vice president of Foxy. So over to Dr. Ragini Agarwal, Madam, for words of blessings for today's program.
Thank you so much, Bharti, for your kind words. Very good evening to one and all, respected seniors and dear friends. So happy to see that NIGF is growing day by day, and nothing is better than having a whole webinar on the cancer cervix when our Prime Minister is going to launch a program for whole India for the vaccination for the under 14 girls. And nobody can be a better chief guest for this program than Dr. Nirja Bhatla, who is an international acclaimed person for the cancer cervix, and I think she's the main advisory behind these programs. Welcome, Dr. Nirja. And I just want to say one thing. The program which is done by the all states, they are very good, and we are giving platform to everyone to come out and show their excellence, their participation, and I request you more and more people should join this new Incredible Gynaecology Forum, that is NIGF, because it is body. It is your regional association of the North India Gynaecology Forum. With these words, my best wishes to you. Have a wonderful, happy learning, and over to you, because everybody is here to listen the academics. And I welcome our past president, immediate past president, Dr. Saad.
Good evening, madam.
After such a long time, Sadhna ji. And Veena madam is also there, and Sarveshi Didi also there. Thank you so much. Please carry on.
Okay. Thank you, Ragini ma'am, for your wonderful words. And now I would like to invite Sadhna ma'am. Just a few words about Sadhna ma'am. She is known all over nationally and internationally, present on all the platforms. But knowing her is a pure happiness, be it spirituality, be it religion, be it politics or academics. I find her amazing. So nothing to talk about you much more, Sadhna ma'am. You are a great personality. I would request you to invite Dr. Nirja Bhatla, our chief guest, introduce her, and let's request her for the words of wisdom.
Thank
Over
you,
to you,
thank
Sadhna ma'am.
Thank you, Amrita. And first of all, congratulations to Hema and Dr. Amrita for organizing always a good program. And again, we are together. And my sincere regards to all teachers, Dr. Veena Acharya, Dr. Ragini Agrawal, who is a close friend and leading North India Gynae Forum with a great momentum and direction. So it's a great pleasure to introduce Dr. Neerja Vatla, whom I have been associated like since 20. I think that it is an association since eternity. So she's a very well-known person and has a landmark and a very, very impressive presence in the field of gynae-oncology, not only internationally, but internationally. She has the Professor Emeritus and CI Chalger, former Professor HOD, AIMS, New Delhi, Council Member of Asian Society of Gynae-Oncology and members WHO DGS Technical Expert Group and the member Policy Committee International Papilloma Virus Society. So when today the government is speaking about the a vaccination, HPV vaccination in our Indian national program, Dr. Neerja Vatla is also one of the main leader and the main person behind this decision. She is academically wonderful and organized with so many conferences, especially on oncology. And this year, the mammoth show of the AICOG 2026 from Delhi, AOGD, and the North. It was the scientific, as a scientific chair, she has given the one of the best scientific program since, we can say, since 4 or 5 conference. So a warm welcome, Dr. Neerja Vatla. You are an inspiration to young generation, and please bless this webinar and all the audience and give your inspiring words on the subject on which you have a lifetime experience. So welcome, Neerja.
Thank you, Dr. Sadhana. इतनी आपने glowing introduction दे दी. Thank you so much for your warm words, and thank you so much to Dr. Hema and Dr. Amrita for conceptualizing this webinar and inviting me to be speaking on it. और हमें तो लगता है कि थोड़ी सी इनमें कुछ वो है सिक्स सेंस जो इन्होंने एकदम ऐसे टाइमली इसको प्लान किया 2 days बिफोर द लॉन्च. जरूर इनको कुछ जानकारी थी जो इन्होंने इस प्रकार से रखा है और सबको एकत्रित कर लिया जो लाइक माइंडेड पीपल हु आर सो मोटिवेटेड. और खैर NIGF के बारे में तो हम क्या कहें कि ब्रेन चाइल्ड डॉक्टर शारदा जैन, डॉक्टर साधना गुप्ता, डॉक्टर रागिनी भी बहुत मन से जुड़ी और सब इतने सीनियर लोग, डॉक्टर सर्वेश्वरी, डॉक्टर माला, डॉक्टर रीना, डॉक्टर श्याम प्यारी, सब जो इतने दिख रहे हैं हमें. और डॉक्टर वीना आचार्य तो वन वुमन शो ऑफ राजस्थान, एकदम सारे बेड़ा उठा के चल रहे हैं. इट्स अमेजिंग हाउ वेल इट हैज कम. आई कंप्लीटली एग्री विद रागिनी. बहुत ही बढ़िया रूप लिया है और बहुत बढ़िया फोर्स से सेल्फ मोटिवेटेड लोगों के साथ जुड़ने से कितना प्रोपेल हो रहा है. इट्स रियली रियली नाइस टू सी. और डॉक्टर साधना के लिए तो मैं क्या कहूँ, सच में एवर सिंस आई वाज इन फॉक्सी as chairperson of the Foxy Oncology Committee, before that sometimes from representing AOGD also, मतलब इतना forcefully ये वहाँ पे खड़ी होती हैं. And I have always appreciated her. You know, she has her convictions and she stands for her convictions. और ये बिल्कुल कहीं झुकती नहीं है, डरती नहीं है बोलने में. तो थोड़ा सा हमने भी कोशिश की इनसे सीखने की कि चाहे वहां पे कोई कहे कि नहीं बोलना है तो हमने बोलना है तो हम बोलेंगे. हम बोलेगा तो बोलोगे कि बोलता है. हम भी तो डॉक्टर साधना आपके फुटस्टेप्स में सब फॉलो कर रहे हैं. आपके पैशन को हर कोई अलग अलग दिशा में चल रहा है बिकॉज देयर इज सो मच टू डू. देयर इज नो वन टास्क एंड इट नेवर कैन गेट ओवर. But the more we can do that, what we do, and that's the main thing. So really today, my greetings to everybody on this gathering, and just a little bit of roundup on where we are with this launch program day after tomorrow, which has been endorsed by the PMO and has been blessed by the PM. And you know, to be honest, we've had a setback of almost 15 years in launching this vaccine because of the unfortunate events of 2010, where unnecessarily some unrelated deaths and mishaps were linked to the vaccine, and it had so much setback. And if we think that roughly 4,000 girls at least every year who are going because to have this problem, then we can see that in 15 years we have a number roughly like 60,000 at least whom we could have prevented by the vaccination, if not more. So we should, think well about that, that we should not allow anything to come in the way. But the same thing we saw with DMPA, the same thing we have seen with HPV vaccination. तब भी वो इतनी वेल मोटिवेटेड लेडीज वहां पे निर्माण भवन के आगे नारे लगाती थी कि वो डीएमपीए से बीगल डॉग्स, आई डोंट थिंक आई एवर सॉ अ बीगल डॉग टिल नाउ, बीगल डॉग्स में ब्रेस्ट नोड्यूल्स हो गए तो हमारी लेडीज को दे रहे हैं। और बहुत उल्टा होता था, तब कहते थे कि हमारी लेडीज को इन्होंने बना दिया गिनी पिग, बीगल डॉग में नोड्यूल्स निकले, अब हमारी लेडीज में लगा रहे हैं, ब्रेस्ट में नहीं लगा रहे। वैक्सीन में उल्टा बोलते थे कि हमारे यहाँ तो ट्रायल नहीं हुआ, बाहर की ट्रायल हुआ, यहाँ पे देना चाहते हो। दे नेवर सेटिस्फाइड वाली स्टोरी है। सो एनीवे, वी आर वेरी हैप्पी सिंस May last year we started getting the installments में the Gavi commitment which is there for countries around the world. ये आप मैप में देखते हैं, अफ्रीका इतने countries ने किया, कैसे किया, it is from Gavi, and lot of attempts are being made to link Gates into this as vested interests. But these are not grants which have any oversight from any particular person. These are grants once given. There are whole committees which run them and decide. And for India, because we are not in the lowermost, there is a certain proportion only that they will give. And this was a long-standing commitment which they have honored. Because in between, there was shortage of vaccine. लोगों की लाइन लगी हुई थी, एक तरफ इम्प्लीमेंट नहीं हुआ था, एक तरफ शॉर्टेज थी, तो वो करते करते हमारी अब बारी आ गई। और जब आ गई तो फिर ये हुआ कि अब इसको कैसे मीनिंगफुली यूटिलाइज किया जाए, बिकॉज यू कांट नेचुरली वैक्सीनेट ऑल द 9 to 14 with this much of dose. So it was decided that the 14-year-old who are going to phase out of this primary target group, कम से कम उनको लग जाए, हर साल 14 साल वाले को लग जाए, और फिर एक समय आएगा कि हम पूरे 9 to 14 को दे पाएंगे। So there is no great vested interest or any doubt about Indian vaccine or anything like that. Indian vaccine has to show antibody stability for 2 years before the WHO criteria of single dose are met. It's as simple as that. And government does not want to start. सर्वेश्वरी जी तो ग्राउंड पे काम किए हैं, इतनी भारी भरकम मशीनरी में ग्राउंड ग्लास रूट तक आप समझाइए फील्ड वर्कर को, who has 100 other tasks on her head also, कि आपने 2 डोज देनी है, फिर आप अगले साल उठ के कहिए नहीं भैया आप 1 डोज है, अब जाने किसको समझ आएगी किसको नहीं समझ आएगी। So they did not want to have this situation. When you see in countries also, somebody is 1 dose, somebody is 2 dose, some 2 dose have not yet decided to move to 1 dose because of these logistic problems rather than any other. So anyway, so they did not want to start. Then they said, okay, we can start with this. And PMO was very concerned that will we be able to maintain the continuity? ऐसा नहीं हो कि ये 2 साल बीत जाए फिर हमारी तैयार ना हो और फिर हमको प्रोग्राम रोकना पड़े. So there's so many things they have to think from the policy maker side. Anyway, वो सारे hurdles हो गए, वैक्सीन सारी डिस्ट्रीब्यूट हो गई. हमारे AICOG के दौरान ही ये सब चल रहा था कि वो मिनिस्ट्री से आदेश दे रहे थे कि अब इनको करो एंड ऑल, मेनली बिकॉज देयर वाज सो मच वैक्सीन, वेयर टू स्टोर इट. CDRI में करनाल में रखी थी, वहां तो फ्रीजर ही ओवरफ्लो होने लग गए. जब वो आए जा रही हैं इंस्टॉलमेंट्स में, कसौली में बैच टेस्टिंग हो रही है, रख रहे हैं, तो उन्होंने धीरे धीरे उनको बांटना और फिर सारे बांट दिए. जब डॉक्टर पवन उधर मिले थे उन्होंने मुझे बताया कि भाई हम आज बांट दे रहे हैं, बिकॉज आई एम चेयरपर्सन एक्चुअली ऑफ द टेक्निकल एक्सपर्ट ग्रुप फॉर दिस HPV रोल आउट. नॉट दैट कोई खास वैसे वो मुझे डाइवर्ज करें. सो देन द पॉइंट इज दैट वो सब हो गया. फिर PMO से सारा एडवर्टाइजिंग मटेरियल अप्रूव हुआ. क्या एडवर्टाइजिंग मटेरियल होगा, और ये सब होने के बाद और ये तय होने के बाद, क्योंकि ये भी किसी को नहीं पता था कब करेंगे, किस दिन सडनली हुआ, तो उतने अब वो एंटी वैक्सर्स शुरू हो गए. तो एंटी वैक्सर्स इस बार मुझे भी खुद नहीं इतने दिखे. कईयों ने ये बात कही है कि हमें तो सोशल मीडिया पे कोई ऐसे दिख नहीं रहे, but they are writing directly to ministry, to health minister, and they are raking up all these old stories कि deaths हो गई, अब उनकी इंक्वायरियां हो गई, सब कुछ हो गया, फिर वो मामले. इसलिए कल से ICMR ने कहा कि आप लोग प्लीज पॉजिटिव ट्वीट्स करिए कि ये वैक्सीन सेफ है, कि ये वैक्सीन इफेक्टिव है, कि इसके कारण इनफर्टिलिटी और ये सब प्रॉब्लम्स नहीं होंगी, और ये एक ही डोज काफी है और 14 वर्ष को दिया जाता है बिकॉज दिस इज द मोस्ट इफेक्टिव एज ग्रुप. मतलब ये वेरियस पॉइंट्स जिस पे कोई कोई अड़ रहे हैं लोग के क्या ये सब थॉट थ्रू है, नहीं है, क्या इंडियन वैक्सीन रद्दी है इसलिए नहीं लिया. नो, दैट्स नॉट थिंग. थिंग इज दैट इट इज जस्ट अ टाइमिंग थिंग, दैट राइट नाउ दिस इज हाउ इट इज, एंड दैट्स व्हाई दे आर सेइंग it is not part of the UIP yet, although it will use UWIN. It is a special campaign mode. And also it was decided to do it in the facilities because अगर स्कूल में उनको ये डाउट हुआ, मिनिस्ट्री ऑफ एजुकेशन, ट्राइबल अफेयर्स, सब लोग बैठ के खूब डिस्कशंस, हम भी बैठे उनमें, उन्होंने कहा हम कंसेंट लेके रखेंगे, अब कहाँ रखेंगे, कितने साल रखेंगे. फिर वो कहने लगे बाकी वैक्सीन में हम लिख के भेज देते हैं घर में कि कल वैक्सीन लगेगी स्कूल में, और यदि बच्चा स्कूल आ जाता है तो इट इज एक्सेप्टेड दैट पेरेंट हैज अग्रीड, तभी उन्होंने भेजा है. तो इसमें लोगों को ये भी डर हुआ कि भैया पेरेंट ने देखा है कि नहीं देखा है, वो पढ़ पाया नहीं पाया, और ऐसे हम अज्यूम करके लगा दें फिर कल को मुसीबत. दैट इज व्हाई इट वाज डिसाइडेड इट विल बी डन इन फैसिलिटी. Let the parent bring the child, then there is no doubt that the parent has agreed because they have brought the child themselves. So that is why right now it is not school based and it is not even class based. It is simple 14 year. अगर वो आगे है पीछे है कौन सी कक्षा में है doesn't matter. 14 उसकी हो गया बर्थडे, 15वां अभी नहीं हुआ, उसको वैक्सीन लग जाएगी. That is the decision that was taken. पहले तो स्टेट वाइज चलना था, तो ये था कि दूसरे स्टेट से अगर कोई आ जाएगी क्या करेंगे ये वो. अब this is going to be a historic moment in history of India. Never any vaccine has been rolled out nationally on one day. And in this one now at 11:30 a.m. the plan is that vaccination वहाँ अजमेर में किसी लड़की की हो जाएगी, वहां पे कुछ वो बना रहे हैं फैसिलिटी. अभी तक तो यही प्लान सुना है, आप लोगों से मैं शेयर कर रही हूँ. और उधर से सारे स्टेट्स लिंक होंगे बाय वीसी विद दैट थिंग. उसके बाद हर स्टेट में अपना लॉन्च कार्यक्रम होगा. Every state, same day. I don't think anywhere in the world it has been done on such a massive scale. So that's the good part of having waited from May till now, that we have the whole system geared. Sub states की training हो चुकी है. Maybe there will be some refresher, but some of you may have seen that operational guidelines का FAQs का booklet which has been made. I can share it also on the group if it's of any help. So I think quite a lot of thought has gone into it. And अब आप लोगों से request है कि आज और कल में आप लोग please खूब सारे videos, posts on your status, on your WhatsApp, on your Insta. WhatsApp to status हो गया, but Twitter they are preferring, and Insta is good because these are the two mediums which people are using for their anti-vax sentiments. So we don't have to counter them, we just have to give our positive, and the senior people, it is requested if they will post, and it will have more impact. And if you will share your links with me, I will pass them on to the ministry and to ICMR who are trying to retweet and amplify them. So thank you for inviting me, and lovely program is ahead. So my best wishes for this program and fingers crossed for Saturday. Thank you.
Hi Neeja ma'am, Bharti here. So nice to hear you. And जो आपका videos या कुछ text materials हैं, अगर वो हमें मिले, अगर बने हुए हैं already, तो please share to us so that we can spread it in 2 days at large level.
Messages जो एक वो मतलब single frames बना के भेजें कि इनको share करने के लिए,
तो please वो आप हमें group में या कहीं share करिए so that we can spread.
मेरे अपने message डाल देती हूँ, और कुछ लोगों ने खैर अपने फॉक्सी वगैरह ने ब्रीफ अपने भी डाले हैं, तो वो मैं डाल देती हूँ.
एक मिनट में आ जाए डॉक्टर नीजा. आई जस्ट वांट टू नो during this later there the campaign will be started by the honorary prime minister, launch campaign from Ajmer.
Yes.
Yes.
That is the thing. Yeah.
Yes.
हाँ,
In the Rajasthan, they will
हाँ,
हाँ.
Yes.
अजमेर में उनकी कोई मीटिंग है, उसमें बहुत सारे प्रोजेक्ट्स का उद्घाटन होना है, तो
मैं मुंह कर जाऊंगी. I will go to अजमेर.
आप
Rajasthan girl is dancing.
2 घंटे में
पता
2
चला
घंटे में
अभी।
पहुंच जाऊंगी. That's why I told, मैं पर्सनली ब्लॉक कर दिया था.
आप पता करिए। और वो प्रॉक्सिमिटी पास एक नया शब्द हमें पता चला अभी जब मैक्रोन आया एम्स, तो किसी की तस्वीर हमने देखी कि बहुत वो खड़े थे मैक्रोन के साथ, तो किसी ने कहा हाँ उन्होंने प्रॉक्सिमिटी पास बनवा लिया था।
नहीं अजमेर में है तो विल सी टू इट. क्या होगा
सैटरडे मॉर्निंग
2 घंटे में पहुंचना मुश्किल नहीं है, वहां तक देखते हैं. लेट्स सी.
पता करा लीजिए, अजमेर जाइए
जरूर.
मैं तो भोपाल में रहूंगी इंडियन मेनोपॉज सोसाइटी के.
हाँ,
तो
आप यहाँ आ जाइए, अपन साथ चलते हैं.
कह रहे थे कि मध्य प्रदेश में पता करते हैं, पर द वंडरफुल न्यूज इज कि सब जगह होड़ लगी हुई है. जैसे सीएम कह रहे हैं कि हमारी होम कॉन्स्टिट्यूएंसी से लॉन्च होगा, हमारे फलानी जगह से होगा, यूनियन मिनिस्टर फलाने अपने करना चाह रहे हैं. सो आई थिंक
हमारे प्राइम मिनिस्टर कर रहे हैं ना,
wanting to take ownership of it and they are so excited about it.
डॉक्टर बाटला, मेनोपॉज तो हर साल होती है. कम टू जयपुर, आई विल टेक केयर.
वो हम जाएंगे तो कहीं पता नहीं कहाँ खड़े होंगे, कोई हमें नहीं बुला रहा है. हम तो बट आपको जरूर बुला सकते हैं बिकॉज यू आर द वन वुमन फोर्स ऑफ राजस्थान.
Yes,
आप
ma'am.
जरूर
Yes,
पता
she
करिए.
is.
I'll go there. And
She has worked a lot on
You
CS service.
represent
Yeah.
us over there for sure.
Yeah, thank you so much. This is such a
ठीक
good
है
news.
जी.
कितनी खुश हो गई मीना जी, जाइए दौड़िए.
आप सबको ले जा रही हूँ. मैं सबका कर रही हूँ. I will make arrangement for everybody. आप सब आ जाए, मैं सबको ले जाती हूँ.
थैंक यू नीरजा, बहुत आपने बातें बताई और ये हम सबको थोड़ा सेंसिटाइज करता है कि डिसीजंस कैसे लेते हैं और उसकी ग्राउंड रियलिटी पे इम्प्लीमेंटेशन के लिए कितने स्टेप्स होते हैं. एंड व्हाट इज आई थिंक दैट व्हेन द पॉलिटिक्स हाउ स्ट्रांगली इट कैन लाइक परफॉर्म पॉजिटिवली. वी ऑलवेज वी से पॉलिटिक्स इज नॉट ए गुड थिंग, बट एक्चुअली पॉलिटिक्स कैन बी अ वेरी वेरी पॉजिटिव फोर्स. So
really great to. एक बात और, मैं सॉरी इंटरप्ट कर रही हूँ, कि कल एक्चुअली वी वर वेरी मच डिस्टर्ब बिकॉज कल बहुत ये इतना एंटी वैक्स हो गया था कि मंत्री जी ने शाम को मीटिंग बुलवाई एंड वी वर रियली ऑन टेंटर होक्स के इस कारण से प्रशांत भूषण एंड पढ़े लिखे लोग इतना उल्टा सीधा बोल रहे हैं. देयर आर मोर डेथ्स फ्रॉम द वैक्सीन दैन फ्रॉम HPV. मतलब कहाँ से ये इंफॉर्मेशन, क्या बेकार की बातें. So anyway, हमको तो लग रहा था कि अब फिर ना डिरेल हो जाए. So it was such a relief late night yesterday when we got to know कि नहीं, program is on, no matter, they just want कि अब आप लोग positive अपना inputs दीजिए ताकि एक positive atmosphere हो जाए.
All that is, Nija, all that is simply politics to go against government. That is all, which is going on right now on each and every subject.
और वो कहते हैं कि कुछ तो ऐसे हैं कि they just want to be in the news, तो चलो ये मुद्दा है, आ जाओ.
नेगेटिव इज मोर पब्लिसिटी ना.
तो वीना जी हो जाए अब, है ना. डॉक्टर साधना, थैंक यू सो मच.
चलो,
टू हैव यू.
मैम आप कंप्लीट करिए अपना जो आप कह रहे थे.
मैं बस वही कह रही थी कि मतलब इट इज एंड like knowing the steps, it is very important for all of us. और हम सब लोग एक मोमेंटम बने. सोशल मीडिया आप उसको पसंद करें या नहीं करें, आपको उसका हिस्सा बनना ही पड़ेगा. एंड AI इज अपकमिंग. तो जो डॉक्टर नीरजा ने मैसेज दिया है कि वी पुट द पॉजिटिव मैसेज फ्रॉम ईच ऑफ अस एंड दैट विल गो अ बिग वे. एवरी कॉन्ट्रीब्यूशन रियली means like that. So Nirja, very timely message, and like we all will be putting on our status and our Instagram. So, and request to all faculties and all our leaders here. So from all the 7 states, so that North India must have a very good voice for the vaccine, which is long due for our girls.
Yeah.
Thank you.
Thank you, Sadhna ma'am, for the wonderful words, and thank you, Nirja ma'am, for all the insights. And as ordinary citizens and ordinary workers, now we get to know what hurdles are there for bringing up such a huge program. So now we are quickly moving on to the first session of this academic program. And the talk is on HPV vaccination itself, the very right time to talk about it. And that would be by Dr. Vandana Verma from Raebareli AIMS. For this, I invite the Honorable Chairpersons, Madam Reena Shrivastava, my teacher, my mentor, and one of the loveliest person I know. She has been the past president of UP chapter of UPCOG, and she is a North Zone coordinator for this vaccination program of SSNPP. And she has worked a lot on this vaccine. And today she is here as a chairperson and will find that what knowledge she has about the subject. And our second chairperson is Dr. Sarveshri Nautiyal, madam. She's a retired director, medical and health, and she has worked at the ground level. She is also a teacher of the National Faculty of HPV Vaccination Program for Prevention of Cervical Cancer. She has been the master trainer of HPV vaccination in Uttarakhand, and she has been awarded Uttarakhand Ratna for the recognition of distinguished services rendered to the society at large. So over to you, chairpersons, and let's move to the academics. Okay.
Thank you, dear Amrita. And it's a very nice occasion to have this webinar today. I'm really so happy working for the last 3 years on this vaccine, making the doctors aware, counteracting every opposite news of it, and every myths we have taken out from the doctor's mind. I'm not going into the details, but lot of work has been done by all the master trainers, all the coordinators, and so many people are sitting over here. They all know, and you two also know. You are also a trainer. I would like to invite Dr. CV Lao unka?
Vandana Verma.
CV Lao.
Vandana.
So Dr. Vandana Verma is here to talk on HPV vaccination. She's additional professor and head department of Ops and Gynae, AIMS Raebareli. More than 13 years clinical and teaching experience, and more than 30 publications in national and international journals, and author of various book chapters. Special interest in high-risk pregnancy, gynecology, and minimally invasive surgery. So, Dr. Vandana, we invite you for your deliberation.
Good evening, everyone. Thank you, ma'am, for my introduction. I am sharing my screen. Is it visible?
Yes.
Yes, ma'am.
Go on.
First of all, I would like to thank the organizers, especially Dr. Amrita ma'am, who has given me the opportunity to talk here on this important topic today on HPV vaccination updates. Going through the disease burden in India, as per the National Cancer Registry Program data, it is the second most common female cancer in women aged 15 to 44 years. It is the second most common cause of female cancer, and around 1.2 lakhs to 1.3 lakhs new cases and 79,000 deaths annually occur in India due to the cervical cancer. Here, as we can see, that 8 out of 10 women infected at some point of time by HPV during their lifespan, and an estimated 1 in 53 women in India will develop cervical cancer. And around 500 million women are at risk of developing the cervical carcinoma during their lifespan. So there is a critical need for comprehensive cervical cancer prevention strategies. The global strategy to eliminate the cervical cancer by WHO says that 90% coverage of HPV vaccination of girls aged 9 to 14 years must be there, 70% coverage of screening with high performance tests by the age of 35 to 45, and 90% women who are identified with the cervical lesion should receive the treatment for precancer and cancerous lesion. So comprehensive cancer care control involves a multifaceted approach to prevent, detect, and treat the cervical cancer effectively. The key components include the primary prevention by vaccination or education and awareness to all the female and their families, and secondary prevention can be done by screening and treatment of precancerous lesions. And it can be, and tertiary prevention can be done by the treatment of the cancer. And all these can be achieved by health system strengthening, which can be done by infrastructure and resources development and integration of the cervical cancer control efforts with other healthcare health services to improve the efficiency and accessibility, and also by focusing on the equity in access to the cervical cancer prevention and treatment services that involve the community leaders and organizations. So before going ahead, we should know what is human papilloma virus and how it can prevent the cervical carcinoma. It's a sexually transmitted virus which transmits through skin-to-skin contact, skin-to-mucosa contact. It is a major global health challenge contributing significantly to cancer morbidity and mortality. It is associated with approximately 4.8% of all the human cancers. It has a single double-stranded DNA molecule of about 8,000 base pairs and encapsulated within a protein capsid of 72 pentameric capsomeres. And it infects the epithelial cells, causing benign warts to cancers. It is classified into high-risk human papilloma virus and low-risk human papilloma virus. The around 13 human papilloma viruses are under high-risk category, out of which 16 and 18 are most prevalent, and they are responsible for around 70% of the cervical carcinoma. Other than the cervical carcinoma, these high-risk HPV causes anal cancers, oropharyngeal cancers in male and female both, and penile cancer in male. The low-risk HPV viruses causes benign conditions like warts and respiratory papillomatosis. As we can see in this table that human papilloma virus is associated with many of the cancers. In cervical cancer, it is responsible for 99 to 100% cases of the cervical carcinoma. Therefore, if 99 to 100% cases of the cervical carcinoma are linked to the HPV, then preventing infection with HPV will definitely help in the prevention of cervical carcinoma. Here, in the natural history of human papilloma virus infection and the cervical cancer development, we can see that the HPV infection occurs in 90% of the male and female during their lifespan, but 80 to 90% of the infection is cleared off by the immune system. However, in 10 to 20% of the women and men, it may causes change in the cervical epithelium and can lead to CIN1. And 60% cases of the CIN1 can become normalized within 1 to 2 years. But if it doesn't normalizes, it can lead to CIN2 and 3. And CIN2 and 3 may lead in 30 to 40% of cases in cervical carcinoma within 10 to 15 years. Therefore, to prevent the cervical carcinoma, if we will give the human papilloma virus vaccine, it will prophylactically. HPV vaccines are composed of virus-like particles which stimulate the immune system to produce antibodies against the viruses and preventing the infection and subsequent development of the HIV-related carcinomas. In India, we have 3 different types of vaccines available. One is the bivalent vaccine, quadrivalent vaccine and nonavalent vaccine. The bivalent vaccine is against the virus 16 and 18 that are the most prevalent virus causing the cervical carcinoma. The quadrivalent vaccine is against 16, 18, 6 and 11 type of HPV virus, and nonavalent vaccine is for 19, 16, 18, 6, 11, and for 31, 33, 45, 52, and 58. All these three vaccine types are formed by recombinant DNA technology, producing non-infectious viral-like particles that is comprising of HPV L1 protein. About the vaccine safety, around 500 million vaccines have been given since 2006, and there is no serious safety issues till date have been found except some cases of anaphylaxis. The Global Advisory Committee for Vaccine Safety is constantly monitoring and has not identified any safety concerns. Adverse events following HPV vaccination are generally mild and of short duration, like pain, redness, and swelling at injection site, and mild systemic adverse events including headache, dizziness, myalgia, arthralgia, and gastrointestinal symptoms like nausea, vomiting, and abdominal pain. The storage of the vaccine, it can be done at 2 to 8 degrees centigrade. It should not be frozen, but it should be protected from the light, and it should be administered immediately after removal from the refrigerator. The vaccine is available as a 0.5 ml dose. It should be given intramuscularly in the deltoid. The primary and secondary target groups. So who are the primary target groups? The WHO recommends the vaccination of girls at 9 to 14 years before attaining the sexual activity, because it is most effective in those persons who are not having the sexual activity. So this is the primary target group for the HPV vaccination. And vaccination of more than 80% females in this age group also helps protect boys from the HPV infection. The vaccinating other groups like female of the older age, boys and men should only be possible and only be done if it is possible and affordable, and it does not take away the resources from the primary group. So schedule of the vaccination. Since 2006, HPV vaccine has been licensed for cervical cancer prevention, initially as a 3-dose regime and then as a 2-dose regime for individuals aged younger than 15 years. Based on the emerging evidences suggesting that 1 dose of HPV vaccine is as effective in preventing HPV infection and cervical precancerous lesion as multi-dose regime. Based on the data of Costa Rica HPV trial and the International Agency for Research on Cancer India HPV trial in 2022, the WHO endorsed a single-dose HPV vaccination schedule in females aged 9 to 20 years. However, in India, according to CDC, FOXI, and National Vaccination Advisory Group, we are using the 2 doses. 2 doses are recommended in the age group of 9 to 15 years. So in the age of 9 to 15 years female, 2 doses are needed that are 6 months apart, and catch-up vaccination can be done up to from 15 years to 45 years if it is not done before 15 years. And in those people, 3 doses are required at 0, 1 to 2 months and 6 months. And in immunocompromised women, whether it is less than 15 years or more than 15 years, in all the females, 3 doses are required, that is at 0, 1 to 2 months and 6 months. And for male immunization, if male is less than 15 years, then the 2 doses are required at 6 months apart. And if the male is of more than 15 years to 45 years, the 3 doses must be given at 0, 1 and 2 months. The Cervavac vaccine is approved. All the other vaccines are approved till the 45 years of age for administration. However, Cervavac, that is Indian make vaccine, quadrivalent, is approved till 26 years for the administration. . Immunization strategy in India. HPV vaccination in India was initiated in Delhi in 2010, marking the beginning of the national effort to combat the cervical cancer. By 2017, vaccination program expanded to some parts in Punjab, and in 2018, Sikkim launched a statewide HPV vaccination campaign across schools. Despite the vaccine being available in private sector, its high cost remains a significant barrier. In 2022, National Advisory Group on Immunization recommended including the HPV vaccine in Universal Immunization Program, and the government allocated a budget for this initiative in 2024. The vaccination program will be launched soon, that is on 28th of the February now, we are knowing, in a phased manner in various parts of the country, targeting the girls aged 14 years and less than who has not attained their 15th birthday. It will be done at Ayushman Arogya Mandir or district hospitals, and it will be voluntary and free of cost. A quadrivalent vaccine will be used in this immunization program. The government had adopted a single-dose HPV regime as WHO with an optional delayed second dose available after 3 to 5 years. HPV drive will be conducted as a special campaign on the designated immunization day and will be tracked through the UN portal to ensure the rapid coverage of the vaccine under the Universal Immunization Program. The benefits of the vaccine. The vaccine is 99% effective if administered in 9 to 14 years of age group and before the exposure to the particular type of the HPV. Other than this direct benefit to prevent from the cervical carcinoma or other carcinoma that the HPV is causing, and the benign diseases that it causes, it develops herd immunity, and this collective herd immunity helps in controlling HPV and cervical and other cancers in turn to the other person who are not vaccinated. In high vaccination coverage countries, studies have shown significant reduction in cases of cancer, genital warts, and precancerous lesions. Special situations for the HPV vaccination. So HPV vaccine can be safely administered with other age-appropriate vaccines in 9 to 14 years of age group. It is not recommended during pregnancy. However, if inadvertently given during the pregnancy, there is no need of doing MTP. It can be administered to the lactating woman. Women with abnormal pap smear or previous HPV lesion can be given with the vaccine if they desire, but yes, it should be counseled to that woman about reduced efficacy of the vaccine and that also that it is not therapeutic for the lesion. Testing for the HPV DNA is not recommended in the HPV vaccination. It does not eliminate the need for screening. It should be done as per guidelines. Conclusion, the HPV vaccination is a major milestone in the prevention of cervical cancer and other HPV-related cancers. It's not a choice, but a responsibility to protect the health of future generations. Adolescent females may have increased susceptibility to HPV infection compared with adults. Exposure to HPV at a younger age increases the risk of cervical lesion and cancers. Cervical cancer prevention starts in adolescence. HPV vaccination is best way to prevent cervical cancer, and it is the most effective when given to the females naive to infection with a vaccine-related HPV type. So don't wait, vaccinate. Thank you.
Thank you, ma'am. Thank you for a great talk. And now over to chairpersons for their comments.
Unmute yourself, Sarveshwari. She's talking.
Yeah.
I think this is an excellent talk, Vandana, and you have covered all the points. And I must say that my North Zone coordinator, Dr. Reena, and my mentor also, she's sitting there. She made us to know each and everything about the HPV. So Amrita will agree with me. And because of her, we learned it.
True.
We know it, and you have told us so many things which are very, very genuine to the general public. They should know. Once they will know it, they will follow it. And they will follow you first if you tell them the reason for why you are giving this vaccine. My mentor told me, if you give a vaccine at the right time, you are saving your patient with good faith. Okay? And the patient will have a good faith in you, and you will have a good faith in your patient. Okay? So it was very good, and HPV vaccine should be given. We are taking so many classes over in Uttarakhand also. UP, I'm from UP, and they included me UP. I must thank Amrita for calling me, for giving me this platform. And I must, each of them, Reena, Dr. Veena Didi, and Shampyari, and Mala, and Meenakshi, and Ragni, I must thank you. You are listening to us. And a special congratulations to Nija. She worked a lot for the prevention of the cervical cancer. I know that. I used to follow her. I used to follow Dr. Jain. So I know Dr. Jain does many things. She has started in Uttarakhand this webinar, and Archana Verma is with her, and she's taking us to spread about the different subjects, BPH. But Dr. Jain is really, I say, she is a person who will make the India cervical cancer free. So I thank you, and I congratulate Nija to you for your achievement. Thank you so much.
I congratulate Vandana. Very nice talk. Very comprehensive.
Yeah.
Right from basics to everything. Very nice. Thank you. Enjoyed.
But I thank my mentor for teaching me nicely. Thank you.
Thank you, Vandana. You have brought out all the important points, very crisp, comprehensive, and we are following, and everybody should follow. And I think many doctors have been trained for this. People know now. 2 years back, there were so many misconceptions.
Yes.
Now, yes, we have trained you can say meticulously, around more than 10,000 doctors working on it. So thank you so much, Vandana, and you have brought the right things. One thing I would like to say that since government is launching a program tomorrow, day after tomorrow, with 1 dose for the girls, we can, and Tyagi has also recommended for 1 dose. And I would like to ask Nirja, in private sectors also we can go for 1 dose to these girls, is it?
I think so. Abhi to last month, dekhiye, CDC has also endorsed 1 dose, because their very big trial came out in December, and that has also found they have done the bivalent and the non-valent vaccine, and they have found them all to be good with 1 dose. So definitely you can go.
Now giving 1 dose will not be against, and we can go for it, and let the GCPR, Foxy GCPR, be revised again for this. This is a launch program. I think it will go to the universal immunization program later, because of the paucity of the doses. Probably this launch is there for only these 14 years girls. Later on, I think it is going to be included. And basically, the India Make vaccine was first time when Adar Poonawalla tweeted. He wrote on his tweet that he has got the permission from DGCI and from MOHFW. That was the date of 12th July 1922. And in September 22, Mr. Jitendra, he announced the making of the vaccine. Then 22nd December 22, they said that yes, now all the states should make the doctors aware, people aware about this vaccine. So we have been waiting for that for the last 3.5 years, and now it is with all of us, and it is so happy moment. And Dr. Nija, you have worked for it with the government. That is creditable.
Yes.
And thank you for all these things. Thank you so much.
एक बात मैं कहना चाहती हूँ, with your permission, रीना जी, कि मैं ये कहती हूँ कि अब ये देखो सरकार का प्रोग्राम आ रहा है, 14 साल का भी करेंगे, फिर आगे आगे वो जो इससे अब वो होती चली जाएगी. So when people are getting money from donors for vaccination, now we should focus on the 15-16-year-olds.
Okay.
क्योंकि वो लड़कियां किसी सरकारी कार्यक्रम में नहीं आएंगी. जो नॉन अफोर्डिंग लड़कियों के लिए हम डोनर्स अरेंज करते हैं, वो हम 15-16 साल वालियों को दे दें, उनको भी एक डोज काफी है. और जो डेनमार्क का डेटा है, स्वीडन का डेटा है, तो अंडर 16, अंडर 17 को भी बहुत बेनिफिट रहा कैंसर
Absolutely right. We can go
should
for
shift our age group for the
and one message that those who can afford, those who are coming to private, we can start from 9 to 14. No problem.
Yes, of course. वो तो आएंगे.
The misconception should not be there that only 14 years has to be given.
No, not at all. और जाएंगी भी नहीं सब. हिस्टोरिकली इस देश में जैसे ही सरकारी प्रोग्राम लॉन्च होता है, प्राइवेट अपटेक बढ़ जाती है. क्योंकि लोगों का कॉन्फिडेंस हो जाता है, लेकिन उन्होंने जाना नहीं है वहां खड़े होने, आना उन्होंने प्राइवेट में ही है. So you should expect that there will be increase in footfall, and we should be ready with the message for them.
Dr. Nisha, only one thing I want to say. आपने रास्ता दिखाया है, लोग उसको फॉलो करेंगे.
Yes.
चलो.
Thank you, chairpersons, Dr. Reena Shrivastava ma'am, Dr. Sarveshwari Nautiyal ma'am, for the great chairing of the session. Thank you, Vandana Verma ma'am, for the talk. And now for the second session, I invite Dr. Apala Pridarshini. She is the assistant professor, AIMS Raebareli. She is the winner of so many awards and gold medals right from her MBBS days to the National Foxy programs and the World Congress. So over to you, Apala, with a great profile. Now you proceed with the second session.
Thank you. Thank you so much, Amrita ma'am, for the nice introduction. And I'm really honored to be a part of this esteemed meeting today. And we now are, without wasting any time, we move forward to the second academic session of the program. And to the talk on a very, very pertinent topic and definitely the flaming need of the hour. And that is the screening for cervical cancer. The speaker for the session is none other than Professor S.P. Jaiswal, madam. She is the mentor of mentors and a clinician par excellence. And as the chairperson for this session, I take the honor to welcome Dr. Veena Acharya, ma'am. Ma'am is the ex-professor and unit head in the Department of Obs and Gynae at SMS Medical College and MGM College, Jaipur. She has been the chairperson of ICMCH, ex-national president of NARCHI, national executive member of ISCCP. She has a huge list of awards to her credit, including the Chikitsa Vibhushan Award, the Appreciation Award by Foxy. And her journey of achievements is too long to describe in such a short span of time, and we are honored to have you, ma'am. We also welcome Professor Dr. Mala Shrivastava, ma'am. Ma'am is the director in gynae oncology, the professor at Gripmer, gynae endoscopy and robotic surgeon at Sir Gangaram Hospital at New Delhi. Ma'am has several prestigious awards to her credit: the Eminent Inspiring Woman Award, Delhi ISAR, awardee of Foxy Achiever Award, and a huge list of awards to her name. She has also served in the capacity of office bearers in various prestigious organizations like the ICOG Governing Council member, the zonal chairperson of ISOPA, AOGD, and we are the list is endless, and we are really honored to have you, ma'am. So I now request the chairpersons to kindly introduce the speaker and commence the session.
Good evening, everyone. It's my pride and privilege to be part of this excellent webinar, excellent learning this evening. And it's also my pleasure to introduce the speaker of the evening, Dr. Jaiswal. Dr. Jaiswal has been the professor and head of IRA Medical College Department of OBGYN, and she has been the ex-professor of KGMU, Lucknow. Madam has been passionate about teaching. We have seen her in many forums, very passionate about teaching to all the young delegates. She had got many awards: International Women's Day Award, Excellent Service Award, Signature International Faculty Award, Outstanding Faculty of the Award, so many awards. And we are waiting to hear from you, Dr. Jaiswal, your scientific deliberation. Over to you.
Thank you, ma'am, for your nice introduction. जरा शेयर कर दो पहले. My slide is visible?
Yes, yes, your slides are visible.
Yes, ma'am.
Now it is full screen or not?
No, ma'am.
Not yet full screen.
Surya?
Not.
Now it is full screen?
Yeah, full screen.
Yes, it is.
And moving also?
Yes, ma'am.
Moving, yes.
Okay, thank you. So really, I'm very grateful. Good evening to all of you, especially my chairperson, Dr. Mala and Dr. Veena Acharya. Both of them are renowned personality and we have interacted at many places. And we know that today's program is related to Dr. Neerja Badla program. And I feel so happy she has brought on the floor to this program because she's working from so many. This is going for so many years. Dr. Vandana, she's already covered the most of the things like the global burden, as we know, and why. But I want to emphasize why that. Surya, जरा से इसको ये हटाओ, जरा स्क्रीन कम आ रही है. देखो जरा से ये पूरी नहीं आ रही है. ऊपर से हटाओ ये वाली चीज.
Oh, wait.
नहीं आ रही, ऊपर से हटाओ. हटाओ अच्छा. Actually, is the screen is visible?
Yes, ma'am. Screen is visible.
Actually, मुझे थोड़ा सा कम दिख रहा है ना.
नहीं, it is okay. It is okay.
It's okay. So why the screening is required in the case of cervical cancer? The cervical cancer, we know this is the second leading cancer among the women in India. According to 2022, around 79,000 new cases comes and 34,000 deaths due to cervical cancer. And this is the second most cancer in the female and is responsible for lots of deaths. And it has long lag period, which we can utilize for the screening purpose. And peak bimodal distribution occur between 30 to 40 and 50 to 60 years of age. Surya, please check it, why it is not moving. This is already covered by Dr. Vandana, and because by 2030, our aim to targets 90, 70, and 90. 90% girls should be vaccinated, 70% women should be screened, and 90% women should be treated. This is our aim. So first, we should know about the cervical anatomy. Maybe it is everybody knows about, but still, why it is important? Because we know the cervix is made by the endocervical and columnar epithelium, which covers the endocervical canal, and outer is covered by the ectocervix. And this junction is known as squamocolumnar junction. And this squamocolumnar junction is the dynamic area, which has changes depending upon the puberty, pregnancy, menopause, and hormonal situation, stimulation. And metaplasia occur in this zone. And when the new squamocolumnar junction formed, and this between the old and new, the transformation zone is appear, which is the area which is responsible for the maximum metaplasia, and 90% cervical neoplasia occur on this place. And this is the picture, which is in diagrammatic presentation. You can say this is the new one, this is the, and this one is the new one, and this is the old one. And in between, this is the transformation zone, in which we can see the opening of the Nemothean follicle. And pathogenesis already discussed by Dr. Vandana. We know this is the HPV genome incorporates in the cervical metaplastic epithelial cells and expresses E6, E7 oncoproteins that suppresses the tumor suppression genes P53 and RB and leads to oncogenesis. And type 16 and 18 account for the more than 70% of disease. And the factors which are high risk is responsible for this persistent and progression of the HPV is immunosuppression, smoking, repeated infection, multiple childbirth, malnutrition, and infection with the other STD. And this is already covered by Dr. Vandana, because every woman who is sexually active have HPV infection. Doesn't mean that every woman will have malignancy, because in the most of the cases it disappears within 6 to 12 months. But it can go into the CIN1, and if it still persists, it can go into CIN2 and 3, and CIN2 3 in 10 to 13% in the duration of 10 to 13 years converts into invasive malignancy. So the diagnosis depends on which type of CIN on histopathology. So we have to know about something about this type of cells also, because this comes into the screening program. But by knowing the cell type, we can know whether this is the normal or abnormal. So when this CIN grade depends upon the nuclear abnormality, differentiation, maturation, and stratification of the cells. According to WHO, this classified into CIN1, which is having mild dysplasia, confined to the lower 1/3 of the epithelium. CIN2 covering to 1/2 to 2/3 epithelium, and CIN3 is almost full thickness, but there is no involvement of basement. Once there is an involvement of basement, it goes into the CIS. So according to National Program of Prevention and Control Cancer, Cervical Diabetes, and this by NHM Ministry of Health, recommended opportunistic screening for disease in every woman more than 30 years. So whenever the patient comes more than 30 years, we should screen. Now come to the why this screening should be universal. Because the cancer cervix has long precancerous lag period, and it prevents more than 80% of cervical cancer, and have 5 years. This is the only cervical cancer which we can pick at early stage and can treat early and give better life to the woman. That's why the screening is very important. How we can screen? The screening are so many methods like cytology, HPV DNA testing, unaided visual inspection. In cytology, we do the pap smear and liquid-based cytology. Pap smear we can do as a routine for every woman who is eligible. And HPV DNA testing, if it is available, it should be done. And otherwise, at the periphery or where there is no facility, even we can do the unaided visual inspection that create the downstaging of the cancer. And by this method, we can use as a via visual inspection after application of 3 to 5% of acetic acid, or with the Lugol's iodine is villi. So these are the things which can be when done by can be performed by a health worker and ladies for the worker nurses. All these we can train on that to pick up the problem in early stage. Colposcopy is definitely required when there is a doubtful. So now come to how we can interpret the result. The NILM is when there is no epithelial abnormality is called as a NILM. Otherwise, we can mention as a ASCUS or atypical squamous cell endermite insignificance, or ASCH, the atypical squamous cell suggestive of HSIL, or low-grade intraepithelial lesion and high-grade intraepithelial lesion. These are the different type of cells we can pick up. In visual inspection of acetic acid, we can see there's a picture, beautiful picture in which we can see in the first picture there is a negative test. The cervix is absolutely fine. Here we can see the acetobite area, which shows that there is some abnormality, because in the abnormal cells have high protein, so it coagulates with the acetic acid and gives white in color. Here we can see the malignant changes after putting the acetic acid. If we put the Lugol's iodine, this is the normal. Mahogany brown is the squamous epithelium. This pink one is the columnar epithelium. Here we can see this pinkish color which is a iodine negative area in the squamous. इसके पहले वाले पे आइए. हाँ, ये this is the summary recommendation of WHO suggests using of following strategy for cervical cancer prevention. For the general population women, screen and treat, or screen, trials and treat is be taken, and this HPV DNA as primary screen test, or we can take, it should be start at age of 30, and every 5 to 10 years screening interval should be there in the normal population. While in the patient with the living with HIV, in that the screen, trials and treat is the only answer, and should be started on 25 years of age, and every 3 to 5 years screening should be done with the HPV DNA as a primary screening test. Next. What do the update guideline of SSCP 2025 says? Next. According to that, the age below 21 years, there is no screening is required. But between 21 to 29 years, cytology alone may be needed every 3 yearly. And between 30 to 65 years of age, any one of the following can be used, like in the form of cytology alone every 3 years, FDA approved primary high risk HPV testing alone every 5 years, or co-testing HPV testing with the cytology every 5 years. So in between these three, anyone can be done. And age greater than 65 years, there is no need of screening after adequate negative prior screening results. And after hysterectomy, when there is no cervix, in that situation, no screening in the individual is required who do not have hysterectomy for high-grade cervical precancerous lesion. Next. So, in the 2025 to 2026 ASCCP cervical cancer screening guidelines emphasize primary HPV testing every 5 years of age between 30 to 65 years, now incorporating self-collected vaginal samples as an option for average risk interval. This is the new things has been added in that. So woman can collect sample herself and send for the analysis. Next. The people who are living with the HIV, in that condition, even the testing should be started as early as at the age of 21 years, according to the adult and adolescent opportunistic infection guidelines. And cytology is not recommended in non-sexually active pre-pubertal children and HIV who is not sexually active or in that condition. About the accuracy of screening tests, the high-risk HPV testing, co-testing detects more CIN3 cases. Co-testing has the highest false positive rate. False positive higher in women less than 30 years. Younger women have more transient HPV infection. Sensitivity and specificity depends on the follow-up protocols. That's why the below 30 years, it is not mandatory to do the vaccination. Screening. Vaccination is required, everyone. In the below 21 years, the cervical cancer is extremely rare. It is less than 1%, 0.1%. And CIN3 prevalence is only 0.2%. False positive cytology is 3%. So there is no benefit of screening before 21 years. That's why they have explained before 21 years is not recommended, except in HIV who is sexually active. Next. Women with 21 to 29 years screening should be done every 3 years with a cytology alone. High transient HPV infection in young women needs more screening. Or if there is a earlier high-risk HPV screening is positive, and then the colposcopy is important. It gives significance. Next. Now come to the management. Because once you have screened the management, as we know that we follow the protocol, see and screen and treat, or see and treat. So in this, the management is also run parallel according to ASCCP 2025 guideline. Next. We have to see the we have to do the risk-based management. In the high-risk condition, we have to do the management then and there. The management recommendation are based on the patient's risk of CIN3 rather than test results alone. Risk is determined by combining current screening result with past screening history. The same test result may lead to different management depending on prior history. Colposcopy can be deferred in selected low risk, because low risk patient, the patient may not require colposcopy. Repeat HPV testing or co-testing at 1 year is recommended for minor abnormality with the low CIN3 risk. Next. This is the flow chart, shows the guidelines how we should risk the patient and how we treat the patient. Like in the immediate CIN3 risk greater than or equal to more than 4%, in that, if it is there, then look for the expedited treatment preferred in 60 to 100%. Expedited treatment for colposcopy is acceptable in 25 to 59%. Colposcopy recommended 4 to 24%. If there is no this high risk, then in that patient to be returned after 1 year or 3 years, depending upon this is the guideline which is given by the CCP. Next. Use of ASCP, there is one app and website is also available. If we can put the these things on that, we can get the result also. So use of ASCP app or website to input current result, HPV cytology, and past history to determine the specific risk which dictates the appropriate clinical action. By this, we can make out the further management also. Next. Expedited treatment guidance, what it says, expedited treatment means see the case and treat the expedited treatment refers to the treatment without a proceeding colposcopy biopsy confirming CIN2 plus. It is preferred in non-pregnant patient age 25 years or older when immediate CIN3 or risk is 60% or higher. It is acceptable when the immediate risk is between 25 to 60%. So whenever we have to calculate the risk factor also along with the CIN on colposcopy biopsy, and if it is the risk is higher, then we have to treat then and there. Expedited treatment is preferred in HPV 16 positive HSIL cytology, and shared decision making is important, especially for patients concerned about the future pregnancy. If the patient is an nulliparous or we want further pregnancy, then we have to think whether we should go for the treatment according to CIN report or not. Come to the treatment and histopathology recommendation. The excisional treatment is preferred over ablative treatment for histology HSIL, CIN2 and CIN3. Excision is recommended for adenocarcinoma in situ. Observation is preferred over treatment for the CIN. In CIN1 needs observation. Histopathology reports should follow WHO terminology and reports should be specify CIN2, CIN3, which are the SSIL. So we have to see which accordingly we have to treat. What about the reflex triage? Reflex triage is a self-collected sample. If the test is positive for high-risk HPV or additional cytology or HPV DNA, testing should be performed on the same sample for the same laboratory. That is important. Once we have seen the sample is all is self-corrected and shows this high risk, should be further evaluated for the DNA testing. In this help identifying the patient that are at higher risk. Colposcopy is warranted in case that the test is positive. HPV 16-18 infection have the highest risk for the CIN3 or an occult cancer. So the additional evaluation like colposcopy with biopsy is necessary even when the cytology results are negative. So we have to see the type of virus also along with the CIN grade. Next. Now come to the post-treatment surveillance. Continue the surveillance with HPV testing or co-testing every 3 years is recommended for at least 25 years after treatment. The risk of recurrence remain elevated for at least 25 years. Cytology alone is acceptable only when HPV testing or co-testing is not feasible. Cytology should be performed more frequently due to its lower sensitivity. Only FDA-approved high-risk HPV assays should be used for the screening and management. Next, now come to the FOXI guidelines. Whatever we have learned about the ACP, now the FOXI guideline, January 2018. Next, just how the CIN should be managed. Management the woman with CIN1 on histology. First, you see the CIN1 either on histology, check the HPV cytology and wire report. If it is ASCUS or LSI, just keep on post-testing every 1 to 2 yearly. If the test negative, the patient will come on the routine screening. In case of high HSL, in that the co-testing should be done in 1 to 2 yearly interval. Still it is persists, then the patient needs colposcopy and biopsy and repeat every 1 year. If again it is positive, then go for the colposcopy and biopsy. If the CIN still persists more than 2 years, then sometime patient needs an ablative procedure. So the ablative procedure should be done when the lesion should be entirely visible and occupy only more than 2 quadrants of cervix. Entire lesion should be located on the ectocervix without any vaginal or endocervical extension. Lesion can be adequately covered with the largest cryoprobe. So these things should be seen when we are doing the ablative therapy. Next, in case of if the patient desire to pregnancy and having CIN1, in that situation, the frequent cytology is required. Repeat the cytology yearly. And if it comes normal, then she will go in for the normal routine screening. But if she comes as a high HSIL or SCUS, in that, repeat the cytology and colposcopy at 6 monthly interval. If show the invasive disease, then manage according to standard protocol. Or if no suggestion invasive disease, repeat the colposcopy yearly and follow the FOXY screening GSC PR guideline. Next, in the case of CIN2 and 3 on histology, in that, review the colposcopy report. If it's adequate, do the lead and ablation and follow the patient with the co-test of HPV 1 to 2 yearly. If test negative, then it comes as the routine screening. But if the Parchin should be negative, if is inadequate or ECC positive, then in that condition, we go for the conization. If still the margin is positive, then patient may require a repeat cone biopsy or hysterectomy. We have to counsel the patient accordingly and or follow the 6 monthly interval. Next, if the patient wants pregnancy, in that we should be very careful because we have to see and follow more closely. And if everything is fine, then it's okay. Otherwise, we have to counsel for the conization or hysterectomy depending upon how much the persistence of the disease. Next, if the CIN detect during pregnancy, then what we should do? See the during pregnancy, see the lesion, whether it belongs to low-grade lesion, then the needs follow-up after 6 weeks of puerperium. But if during pregnancy is towards the higher grade, then in that situation, we have to repeat the colposcopy every trimester to rule out the invasive disease and repeat after 6 weeks of postpartum. But if the patient shows the invasive cancer, in that situation, we have to see the gestation age. And depending upon the gestation age, we have to manage the patient. Next, in case of AIS, in that situation, if the already ECC is positive or endocervical canal shows the positive of intraepithelial neoplasia, in that situation, the conization is the rule to take out the disease. But if we have to consider, because depending upon, we don't know how much the metaplasia is inside, in that situation, we have to consider the patient for the hysterectomy. The patient is young and need fertility. In that, we have to do the repeat and see the margin. If the margin is fine, then it's okay. If the margin is still doubtful, then we have to go for the repeat, or ultimately patient will land up in the hysterectomy or the need close follow-up if she wants the pregnancy. Next. Now come to the conclusion. The HPV is a virus, we know. HPV types are classified in the various ways, including the high risk and low risk. HPV 16, 18 together are responsible for more than 77% of cervical cancer. And we have to follow the 90, 70, and 90 target. It must be met by the 2030. Reporting of cytology should be done based on the Bethesda. Screening is now recommended for self-collected sample. Next, follow-up with the colposcopy is required for high-risk HPV DNA types, HSIN, CIN2 and CIN3 cytology. As per SP 2025 guidelines, women aged more than 21 years should be screened with the cytology 3 yearly. and women between 30 to 65 years age can be screened by cytology, high-risk HPV and co-testing. As per FOXI guidelines, every woman aged more than 18 years should be screened with cytology every 3 yearly. Although the vaccine is preventing the malignancy, and this is the cancer which is preventable by the vaccine, but screening is required for vaccinated individuals. So even the patient is vaccinated, still she needs screening as a routine, depending upon her age or other high risk factors. Thank you so much. Thank you. Sorry.
Thank you. Yeah,
I'm not able to.
Mary, for discussing such extensively, and you have also covered the management part regarding the screening and everything. So it is really, you have not left anything, and the risk-based management you have discussed in such a detail, which is hardly covered by anybody. But what I want to say, we have the cafeteria choice of the screening. You do whatever the method you want to do with the screening, because today we are here for the 90, 70, 90. She has discussed everything. So whatever the NCD program is 2016, but it does not fruitful because it covered many other diseases, non-communicable diseases with other diabetes, this. So ASHA workers are not fulfilled to doing the VIA, because that is not only focus of VIA. But recently in 2025, the government has launched another program to cover every woman for the extended VI program. So that is that they are dying. But do you realize how can we go for the PAPS test in the grassroots level? We can't go for the 150 or 200 women with the PAPS smear, because doing the PAP smear, follow-up and treatment is quite difficult for everyone. But what I'm doing at grassroots level nowadays, I'm going with the VIA superimposed by the AI methods. So with that, I'm doing the testings, and 100 of women, 80 are coming normal and 20 are coming atypical or abnormal, that I go for the further management. But it is really difficult to screen the women. Vaccination we will cover today, that was very good news. But we have to focus on the screening, and that is my request to do the via HPV DNA, as WHO is described, is the primary test for the screening, whether it is feasible or not. But please do whatever the test is feasible for us. Thank you so much, Dr. Shyam. I'm going for another CME, so I'm a little bit in a hurry. Thank you so much.
Yes, madam. As we know, we travel from the village to the higher center. So depending on the situation, we have to manage. That's why we have lots of this program going through the government to teach everyone how we do the how do the villi. That is the beginning stage. But by this, we can pick up the high risk cases, and if we have facility, definitely the co-testing will be better. And it reduces the time, it increases the time interval also, and is more definite. But still, via we can pick up many patients and treat then and there rather than going further. Thank you so much. And when any case, when there's a doubtful, we can go to the trials. I'm really sorry, ma'am, because of network problem.
I'm going for another.
Thank you, ma'am. Thank you so much. Thank you.
Excellent lecture, Dr. Jaiswal. You have covered each and every point nicely, and you have nicely shown the slides and how to do the screening. And all the patients who have got their vaccination should and must go for screening at least twice in their lifetime. And that is how we can prevent or eliminate cervical cancer, maybe by 2030. Excellent lecture.
Thank you. Thank you so much. Thank you.
Mala, you're looking very beautiful. Dressed up so well.
Thank you.
Mala? Always.
She's always very well dressed up.
Dr. Neerja, any comment? I'm really sorry because of my network problem.
नहीं बहुत बढ़िया लेक्चर था और आपकी स्लाइड्स बहुत बढ़िया थी.
अब मैं क्या बताऊँ? दिखाई नहीं पा रही थी मैं, तो क्या बताऊँ? चलिए, thank you so much, because my aim to cover from as we worked in the government college, we know that we have trained so many people, medical officers, nurses, all for the VIA and all these things under the so many training program. But I feel if it goes to the periphery and screening starts from the periphery, at least we can pick the person in time, and we have enough time to manage these cases. And by this, definitely we will be able to reach our goal.
But the periphery is short of infrastructure and short of people, and those ASHA workers and midwives, they are overburdened with the work. वो काम भी करना है उनको, उसमें कंप्यूटर में भेजना है उनको, टेटवेक लगाना है उनको, फील्ड में जाके मरीज भी देखना है. Everything is being shouldered by them, and I don't think they would be able to do justice to these types of programs.
बात तो बिल्कुल सही है रीना जी.
Till now the screening
टीम
is so less in India, 5% से कम है.
अभी यूएस से एक टीम आई थी, या केजीएमयू से भी, एरा से भी, पूरे कई रेजिडेंट हमारे गए थे, और उन्होंने सेल्फ कलेक्शन वाला भी बताया था. दे हैव क्रिएटेड स्मॉल प्लेस फॉर द सेल्फ कलेक्शन, एंड देयर दे डिड द और ट्रीटेड आल्सो. तो मुझे ये लगता है कि वो लोग उतनी दूर से यहाँ से आकर कर सकते हैं काम, तो हम लोग क्यों नहीं कर सकते?
वो सिखा रहे हैं ना आके, तो तुम अपना काम जो कर रही हो कॉलेज में, उसके अलावा जाके क्या पूरा पेरिफेरी कवर नहीं कर सकती? यू हैव टू टीच द पीपल, एंड वी हैव टू इंक्रीज द नंबर ऑफ पीपल एट द पेरिफेरी. ये बात गवर्नमेंट को समझ में आनी चाहिए.
बिल्कुल.
Each and every program is being shouldered by them, and they are practically they are not able to do it. So वो कभी कुछ करेंगे, कभी कुछ करेंगे. जितने प्रोग्राम आते हैं पेरिफेरी में जाके वहीं अटक जाते हैं.
तो बिकॉज ऑफ पॉपुलेशन बर्डन, उस पर तो हम लोग कुछ कमेंट नहीं कर सकते ना. लेकिन जो
लोगों को बढ़ाना चाहिए गवर्नमेंट में. पीपल, I think it is going live on this thing. ये live जा रहा प्रोग्राम कहीं. Let the people understand this problem.
बिल्कुल सही बात. चले करेंगे, कुछ ना कुछ तो कर ही लेंगे. अगर सब लोग मिलेंगे तो कर ही लेंगे.
Practically possible होना चाहिए ना. Whatever program is being launched, it should be practically possible. वही लोग जाके, अभी इलेक्शन आएगा तो उसमें भी वही लोग सब काम करेंगे. वही लोग आके फिर, तो हाउ कैन इट बी डन बाय द सेम पीपल हु आर हैविंग सो मेनी, जितने सारे नेशनल प्रोग्राम्स हैं, सब अल्टीमेटली वहीं पे जाके शोल्डर हो रहे हैं. सो इट इज वेरी डिफिकल्ट. नेट नहीं काम कर रहा है, कभी कोई चीज प्रॉब्लम है, कभी कोई प्रॉब्लम है. प्रोग्राम तो सब बहुत अच्छे वाले हैं.
ये भी नई वाली गाइडलाइन में ये भी है कि आपको नेट फैसिलिटी भी होनी चाहिए. वहीं आप उसको तुरंत भेज दीजिए.
अभी जो परसों प्रोग्राम लॉन्च हो रहा है उसमें नेट फैसिलिटी चाहिए. यूविन पे आएगा, उसमें आपको सबका रजिस्टर करना है, तब लगाना है.
अब यूविन तो बिना नेट के चलेगा ही नहीं ना. ये हाल है. सोचो लखनऊ में बैठे हुए हैं तो हमारा लैपटॉप नहीं काम कर रहा है, तो पेरी
इनिशिएटिव इज वेरी गुड. द इनिशिएटिव्स आर वेरी गुड. 100% तो हम अज्यूम भी नहीं कर सकते, लेकिन ये स्क्रीनिंग प्रोग्राम, मतलब आई एम जस्ट टायर्ड के बहुत सालों से चल रहा है, एंड वी आर नॉट एबल टू कैप्चर ऑल द लेडीज.
बहुत सालों से हो रहा है. मतलब हम लोग, मतलब व्हेन वी वर यंग लेक्चरर, तब से शुरू हो गया था. तब भी मतलब क्या बताया जाए आज. लेकिन फिर भी मैं, दिस इज माय ऑब्जर्वेशन, जो स्टेज आते थे ना, 3, 3rd, 4th स्टेज में आते थे,
वाले अब नहीं आ रहे.
अब तो फिर भी पेशेंट दे कम एट अर्ली स्टेज, एंड डाउन स्टेजिंग तो हुई है, देयर इज नो डाउट. जैसे हम लोग के शुरू में आते थे एकदम एडवांस स्टेज वाली मैलिग्नेंसी आते थे, वो तो थोड़े
आते थे, जो कि आपको स्मेल पहले आती थी और मरीज बाद में आता
था.
वो अब नहीं आते हैं.
हाँ, वो वाली स्टेज नहीं आता.
वो स्टेज अब नहीं आ रही है.
आते हैं तो जो
साल में कभी एक आदमी मिल गया तो मिल गया.
बहू ने देखा कि स्टेन लग गया माता जी की साड़ी पे, तब वो लेके आई, बोलती थी.
Yes.
तो अब वो
एक्चुअली वुमेन दे नेग्लेक्ट देमसेल्फ आल्सो ना. ये वाली बात है ना, बिकॉज ऑफ लैक ऑफ अवेयरनेस. लेकिन फर्क तो पड़ा है. मतलब हमारे
बहुत फर्क पड़ा है.
बहुत फर्क पड़ गया. चलिए, बहुत अच्छा रहा. थैंक यू सो मच फॉर इनवाइटिंग. सॉरी अमृता.
अरे मैम, इतना अच्छा था सब. थैंक यू. वी आर सॉरी कि हम लोग आपको अच्छे से सुन नहीं सके.
क्या बताऊं, मुझे लगा कि
जी, लेकिन सब एंड में सब हो गया.
डटे रहे के सुन के ही जाएंगे.
आई रियली थैंकफुल टू यू यार.
And Nirja ma'am, thanks a lot. You spared so much time for this program. Thank you so much.
That is creditable Nirja.
मैम, बहुत बड़ी बात है.
थैंक यू अमृता, तुमने मुझे बुलाया और इतने लोगों से मिलने का मौका मिला.
बहुत अच्छा.
Apala, you go on with the formal thanks.
Thanks, ma'am.
Thank you. Thanks.
Yes, ma'am. So as we come to the end of this academic extravaganza, it is indeed a proud privilege and honor for me to propose the vote of thanks. And first and foremost, I extend my heartfelt gratitude to our esteemed chief guest, Dr. Neerja Bhatla, ma'am. Your gracious presence and words of inspiration have truly enlightened us all and will continue to inspire us always. And needless to say, it is a real honor for us to have you with us today. My sincere naman to our Honorable Chief Patron, Dr. Sharda Jain, ma'am, for setting the magnanimous footsteps for each one of us to follow. Our esteemed President, Dr. Ragini Agarwal ma'am, and Secretary General, Dr. Sudha Sharma ma'am, for being the torchbearer to enlighten us today and always in all our academic ventures. My regards to Dr. Sadhana Gupta ma'am for nurturing the forum from its roots, Dr. Hema Shobhane ma'am, Dr. Bharati Maheshwari ma'am, and Dr. Amrita ma'am for propelling its prestige always and for weaving us all together like a family. My most sincere thank you to our distinguished speaker, Professor S.P. Jaiswal ma'am, for her priceless insights on screening of cervical cancer, and Dr. Vandana Verma ma'am for reinforcing so wonderfully the intricacies of HPV vaccination. My earnest gratitude to our respected chairpersons, Dr. Reena Srivastav ma'am, Dr. Sarveshwari Nautiyal ma'am, Dr. Veena Acharya ma'am, and Dr. Mala Srivastav ma'am for sharing your expertise and for making the discussion meaningful. A large word of appreciation to our technical team, Roshan ji, for the seamless support and coordination. And finally, a big, big thank you to all delegates for sparing the time to be with us today and making the program successful. And as Hema ma'am initially said, coming together is just a beginning. Keeping together is progress, and working together is success. And the success of this endeavor will only be worthwhile if we all work together for the elimination of cervical cancer by vaccinating, screening, and treating in whatever capacity we can. And so that we can meet the apt theme of this webinar, 90, 70, 90. And we do hope that we will all do our best to contribute to this endeavor. Thank you, one and all, and long live NIGF.
Thank you. Thank you,
Apala,
Apala.
you are so sweet.
Nice
Wonderful.
words.
Nice
Nice words.
ये बहुत छोटी सी थी ना जब गोरखपुर में थी तो।
हाँ, जब हम इसको गोरखपुर में लेके आए थे तब पूरे कैंपस में डाला करती थी रीना जी, याद है
So
आपको?
sweet.
Apala
Now
is
she's
my
so sweet.
daughter.